Welcome to the deep dive. We take source material you've shared, could be articles, research, even your own notes, and we really plunge right in.
Yeah, our goal is to surface what's most important, the key facts, maybe those surprising bits so you can get informed quickly without getting bogged down.
Exactly. We navigate the info for you, pull out the crucial stuff, and help make sense of it all.
hmm
And today we are tackling a really tough topic in veterinary medicine. Our source material is this detailed text on peritonitis in dogs and cats.
It's a condition that's incredibly serious, requires intensive care. This text gives us a real window into how it works and how it's managed.
So our mission for this deep dive,
Yeah.
dig into this source, understand what peritonitis actually is, how this dangerous process unfolds inside the abdomen.
Yeah, and how vets figure it out, how they diagnose it, which isn't always straightforward.
Right. And what that really intense treatment process looks like. We're extracting the essentials from all this information.
Okay, let's get into it.
All right, so starting with the basics from the text, what is peritonitis?
Well, the source defines it clearly. It's an inflammatory process involving the lining of the abdominal cavity. That's the serous membrane, the peritoneum.
Okay, inflammation of that lining. How does that even begin? What kicks it off?
According to the text, it starts with some kind of insult, some damage or contamination within the peritoneal cavity. Could be localized, just one spot, or it could be spread, generalized.
And that insult triggers the inflammation.
Exactly. It sets off this whole cascade.
What does that cascade look like inside the body?
The research describes a few key things happening pretty quickly. Vasodilation, the blood vessels widen, immune cells start moving into the area, pain fibers get stimulated, which is why it's often so painful.
Makes sense.
And then adhesions can start forming. That's where tissues kind of stick together abnormally.
Adhesions,
Yeah.
like internal scar tissue. That sounds problematic.
It definitely can be. And how bad that initial insult is really drives how widespread and, well, how intense the whole reaction becomes.
The source material seems to put a lot of focus on bacteria playing a role. How do they fit in?
Ah, yes. This is where the cellular detail in the text gets interesting. If you have gram-negative bacteria involved, they have this component called endotoxin, or LPS. It's a major trigger.
A trigger for what?
It binds to immune cells, like macrophages, and makes them release these inflammatory messenger molecules, cytokines, things like IL-1 and TNF.
So the bacteria make the body send out alarm signals.
What about gram-positive bacteria? Are they different?
They are. They have different triggers on their surface, like peptidoglycan and tetroic acid. They also cause cytokine release, IL-1, TNF again. But the text notes they also trigger the release of nitric oxide, NO.
Nitric oxide.
Right.
What does that do in this situation?
Well, the source points out that NO causes significant vasodilation, widening of the blood vessels, and that can actually lead to a dangerous drop in blood pressure.
Wow, so the body's own response can lower blood pressure. That seems
Yeah.
risky. It is. It shows how this whole inflammatory thing can get out of control. And there are other substances involved too, mentioned in the text: histamine, serotonin. They also cause vasodilation and, importantly, increase vascular permeability.
Permeability, so things start leaking out of the vessels.
Precisely. That leads to fluid building up in the abdominal cavity. Plus, you have all these inflammatory cells releasing more cytokines, which pulls in more immune cells. It's called chemotaxis.
Okay.
And it activates another part of the immune system called complement. All of this just adds to the fluid accumulation.
It sounds like a vicious cycle. The inflammation just keeps feeding itself.
It really can. And that complement activation, combined with something called decreased fibrinolysis, that's the body's clot breakdown system not working properly, actually damages the peritoneal lining itself, the mesothelium. And that's what leads to those adhesions we mentioned.
So the body's repair attempts kind of backfire and cause more damage, like the adhesions. Does the source mention anything specific leaking into the abdomen that makes things even worse?
Yes, it specifically calls out bile and blood as being particularly problematic.
How so? What does bile do?
Bile directly damages those mesothelial lining cells. And maybe even worse, it inhibits the function of certain white blood cells, the neutrophils, which are supposed to be cleaning up the infection.
So bile damages the lining and hinders the cleanup crew. Okay, what about blood?
Blood in the abdomen messes with chemotaxis and phagocytosis, basically, the ability of immune cells to move to the problem and engulf bacteria and debris. And blood also provides nutrients that actually help bacteria grow.
Okay, so we have this escalating mess inside inflammation, fluid, adhesions, bacteria potentially thriving in nasty stuff like bile or blood. What's the big danger here? The source mentions systemic effects.
This is absolutely critical. Severe abdominal inflammation, according to the text, rarely stays just in the abdomen. It can trigger a massive body-wide inflammatory state. That's called systemic inflammatory response syndrome, or SIRS.
Surged, okay.
And if bacteria are involved, which they often are in secondary peritonitis, that progresses to sepsis.
Sepsis.
And if SIRS or sepsis isn't controlled, it can lead to multiple organ dysfunction syndrome, MODS.
MODS, so multiple organs start failing.
Exactly. The text details how this can impact the lungs, maybe causing acute respiratory distress syndrome or blood clots. It can damage the kidneys, affect the heart, even cause neurological issues. It goes from being a local problem to a full-blown, life-threatening systemic crisis.
Wow, that really paints a picture of how serious this can get. So who tends to get peritonitis? Are certain pets more susceptible?
Well, the source is quite clear on this. It affects both dogs and cats. And interestingly, it doesn't seem to identify any specific breed, age, or sex that's more likely to get it.
Okay. And what might someone notice? Are the signs usually obvious?
That's one of the challenges the text highlights. The signs can actually be quite vague, especially early on, very nonspecific. They really depend on how far the inflammation has progressed and whether that systemic response, SIRS or sepsis, has kicked in.
What kind of subtle things are we talking about?
Things an owner might see, according to the source, could just be general lethargy, maybe depression, not wanting to eat, maybe some vomiting or diarrhea. In really severe cases, collapse.
Okay. And on a vet's exam, what are the key findings?
Abdominal discomfort or pain is a big one. It might be focused in one area, or the whole belly might be tender. Pets often tense up or guard their abdomen when it's palpated. Though the text does note that cats sometimes show less obvious pain on palpation compared to dogs.
I think I've heard of a specific stance they might take.
Yes, the prayer position. That's where they're down on their front legs with their rear end up in the air. It's thought to relieve some of that abdominal pressure and discomfort.
And if that systemic response, SIRS or sepsis, is happening, what does that look like?
The source describes the signs of shock. In the early stage, compensatory shock, you might see a really fast heart rate, rapid breathing, maybe bright red gums, and quick capillary refill time. But as it worsens, moving into early decompensatory shock, the heart rate might still be fast, but the pulses feel weaker. The pet seems dull, depressed. Gums might look pale, and that capillary refill time gets longer.
It seems like standard shock signs, but wasn't there a specific point about cats in the source?
Yes, and this is a really important nuance from the text. Cats, unlike dogs, often show a normal or even slow heart rate, like less than 140 beats per minute, even when they're in early shock. That's a key difference.
Good to know. And full decompensatory shock.
Then both dogs and cats typically show bradycardia, a very slow heart rate, really weak or even absent pulses, severe mental depression, pale or bluish gums, and a very prolonged CRT.
Are there other common signs?
Vomiting is very common. Heart rhythm irregularities, arrhythmias can happen too. And fever isn't always there. The text emphasizes that.
Yep.
But if there is a fever along with these other signs, it strongly suggests bacterial contamination is involved.
Interesting.
Also, the data referenced in the source mentioned weight loss being reported in about a third of cases of secondary peritonitis.
Okay, so we understand what it is, how it develops internally, and what it might look like. Now, the big question, why does it happen? What actually causes it?
The source differentiates two main types. First is primary peritonitis. This is actually pretty uncommon. It happens when bacteria spread through the bloodstream or lymph system or somehow migrate through the gut wall, even without an obvious hole. Feline infectious peritonitis, FIP, in cats is actually mentioned as a form of primary peritonitis.
So primary is rare. What's the usual scenario?
Secondary peritonitis, that's the one vets see most often. It's caused by contamination leaking into the abdomen from an organ inside.
Leaking from an organ. Which organs are the usual suspects?
The GI tract, the gastrointestinal tract, is the biggest one. The source says up to 75% of secondary cases originate there.
75%? Wow. What kind of GI problems?
Things like perforation of an ulcer or a tumor, rupture associated with bloat, GDV, leakage after a GI surgery, maybe the stitches didn't hold, or penetrating trauma, like getting stabbed or shot. Other sources mentioned in the text include the biliary tract, the gallbladder, or bile ducts rupturing, maybe due to a blockage or a gallbladder mucocelli.
Okay.
Abscesses in organs like the pancreas, kidney, prostate, spleen, or liver can rupture and spill infection. A ruptured pyometra that's an infected uterus is another cause. and urine leaking into the abdomen, which is called uroabdomen.
You mentioned uroabdomen and bile leakage. Are those always caused by bacteria?
Good question. The source clarifies they can be non-septic, meaning no bacteria initially. But urine and bile are so chemically irritating to that peritoneal lining that they still cause severe inflammation. So it's a chemical peritonitis in those cases, even without bacteria.
Right, still very serious.
Yeah.
Are there things that make a pet more likely to develop this? Risk factors.
The source lists a few. Trauma is one. Having had recent GI surgery is another. Undetected abscesses in organs like the liver, pancreas, prostate, or uterus. And there's a specific link mentioned in the text. Prior use of NSAIDs, non-steroidal anti-inflammatory drugs, seems to be associated with perforations occurring more often specifically at the pylorus, which is the exit point of the stomach.
That's a very specific finding. Okay, so if a vet suspects peritonitis, how do they confirm it? What are the crucial diagnostic steps?
Well, first, they'll think about other things that could cause similar signs. A differential diagnosis for severe abdominal pain, shock, or sepsis coming from somewhere else.
What about blood tests? What clues can they offer?
Blood work is really important, especially for seeing those systemic effects. The source notes a common finding is neutrophilia, an increase in neutrophils, sometimes with immature ones out in circulation. That's called a left shift. But here's a key prognostic point highlighted. If the neutrophil count is actually low, neutropenia, or if there's what's called a degenerative left shift, the source says that suggests a worse prognosis.
Okay, so low white cells can be bad here. What else?
You might see hemoconcentration, meaning the blood is thicker due to dehydration or sometimes anemia. Low protein is common, often because albumin is leaking out into that abdominal fluid. Electrolyte problems are frequent potassium too high or too low, low sodium. Azotemia, indicating kidney issues, which could be pre-renal, renal, or post-renal. Metabolic acidosis is common too.
What about glucose?
Glucose levels are important. Hypoglycemia, low glucose, can be a sign of sepsis because bacteria use it up. Interestingly, in cats, you might actually see hyperglycemia, high glucose. You might also see elevated liver enzymes, either because the liver is the source of the problem or because of MODS. And hyperlactemia, high lactate, is common because of shock and poor tissue perfusion.
Are there other lab tests mentioned?
Yes, the research mentions clotting abnormalities are common. Tests like APT and PT might be prolonged. Something called thromboelastography can give a more detailed picture of clotting. And you might see signs of DIC, disseminated intravascular coagulation, a really severe clotting disorder. The text mentions things like prolonged APT-PT, low platelet counts, and elevated D-dimers as signs of DIC.
So the labs show the systemic fallout. What about looking inside? Imaging, X-rays, ultrasound.
Radiographs, X-rays can be helpful, but the findings are often inconsistent, according to the source. You might see a loss of detail, kind of a hazy or ground glass look in the abdomen because of the fluid, but the text cautions that very thin animals without much fat can look similar.
Okay.
The intestines might look distended and not moving properly, that's ileus, but the really key finding on X-ray, if it's there, is pneumoperitoneum, free gas in the abdomen.
You asked me.
It usually means something has ruptured, like the GI tract. Even a small amount of free gas, especially seen on specific X-ray views, like a horizontal beam shot, can be diagnostic. X-rays might also show masses or enlarged organs, but the text strongly warns against using contrast material, like barium, if you suspect a perforation, because barium itself is extremely irritating if it leaks into the abdomen.
Got it. No barium if rupture is suspected. What about ultrasound?
Ultrasound is very useful here. It's much better at detecting smaller amounts of abdominal fluid that might be missed on X-rays. Crucially, it can often help pinpoint the source of the problem, finding an abscess, maybe a ruptured gallbladder or a tumor. And importantly, the source highlights that ultrasound is really valuable for guiding a needle to collect a fluid sample, especially if there isn't much fluid present.
Ah, the fluid sample. The source seems to indicate this is one of the most critical diagnostic steps, right? Getting that abdominal fluid.
Absolutely. Abdominocentesis, just sticking a needle in to get fluid, or diagnostic peritoneal lavage, DPL, are highlighted as being safe, reliable, and really should be done early if peritonitis is suspected.
How do they actually get the sample?
Well, they prep the area sterilely, make sure the bladder is empty, then they use a needle or a catheter to puncture into the abdominal cavity. The text stresses collecting the very first drops of fluid for analysis right away. If fluid doesn't flow freely, they apply gentle suction. The recommendation from the material is often to try tapping in multiple locations, usually all 4 quadrants, saving the left side for last to try and avoid hitting the spleen. Ultrasound guidance, as we said, can really help target fluid pockets.
What if they try that but don't get any fluid and they still strongly suspect peritonitis?
That's where diagnostic peritoneal lavage, or DPL, comes in. It might be done if you're highly suspicious, maybe after surgery where you expect some inflammation but want to check for infection. The procedure involves carefully infusing a specific amount. The text says 20 milliliters per kilogram of body weight of warm, sterile saline into the abdomen using gravity. They let it dwell for a bit, gently roll the patient to mix it around, and then collect the fluid back out. You don't need to get all of it back.
Okay, so they've got the fluid either directly or via lavage. What are they looking for in that sample that confirms peritonitis?
This is really key, according to the source. First, they look at it under a microscope cytology. Finding certain things is considered diagnostic for septic peritonitis.
Like what?
Seeing bacteria, either inside or outside of cells, seeing degenerate neutrophils, those are white blood cells that look damaged and unhealthy, or even finding things like plant material, which obviously shouldn't be there. Normal abdominal fluid has very, very few cells.
So seeing bacteria or those damaged white cells is basically proof.
For septic peritonitis, yes, according to the text. And here's another really specific, crucial marker highlighted in the source material. Comparing the glucose level in the abdominal fluid to the glucose level in the blood.
Okay.
If the fluid glucose is more than 20 milligrams per deciliter lower than the blood glucose, that is highly suggestive of septic peritonitis.
Why is that?
Because the bacteria and inflammatory cells in the infected fluid are consuming the glucose, so its level drops significantly compared to the blood.
Wow, that's a really neat diagnostic clue from the source. Very specific.
It is. So besides cytology, they'll send the fluid for bacterial culture and sensitivity testing. That tells them exactly which bacteria are present and which antibiotics will be most effective.
Makes sense.
And if they suspect a chemical peritonitis, like from urine or bile, they'll analyze the fluid for specific substances. High creatinine points to uroabdomen. High bilirubin points to bile peritonitis. High amylase might suggest pancreatitis is involved.
How high do they need to be?
The material states that finding bilirubin or creatinine levels in the fluid that are higher than the levels in the blood confirms bile peritonitis or uroabdomen, respectively. They might also look for a cellular mucoid material on cytology, which suggests bile.
And for FIB in cats, you mentioned that earlier.
Right. For suspected FIP, the fluid analysis would focus on protein levels, specifically looking at protein electrophoresis and globulin levels, which can support that diagnosis.
Okay, so diagnosis relies on the whole picture signs. Labs showing systemic effects, imaging clues, but analyzing that abdominal fluid seems absolutely critical for confirmation and guiding treatment. Once it is diagnosed, how is it treated? Sounds incredibly serious.
It absolutely is. The source emphasizes it requires inpatient, intensive monitoring and supportive care. It's not something treated lightly.
What's the very first step in treatment?
Intravenous fluids. IV fluids are critical. The text really stresses that correcting the hemodynamic problems like shock, low blood pressure, and stabilizing electrolytes and acid-base balance is essential before the patient can even go to surgery.
What kind of fluids do they use?
They usually start with balanced electrolyte solutions, like LRS or normal Sol-R. The source notes the initial infusion rates can be really high, up to 55 milliliters per kilograms in cats, 90 milliliters per kilogram in dogs per hour initially for shock resuscitation. They need constant reassessment and adjustment based on the patient's response.
Okay.
They might need to add potassium or glucose supplements to the fluids. And colloid fluids like hetastarch or plasma are often highly recommended in severe cases to help maintain blood pressure and oncotic pressure.
Are there specific goals for the fluid therapy?
Yes, the material lays out clear targets, maintain systolic blood pressure above 90 millimole Hg, get the heart rate into the target range for the species, ensure capillary refill time is less than 2 seconds, maintain good urine output at least 1 to 2 millimoles per kilograms per hour, and get the serum lactate level down below 2.5 millimole, especially in dogs, as that indicates perfusion is improving.
What if fluids alone aren't enough to meet those goals?
Then the text discusses considering vasopressor medications, drugs like dopamine, dobutamine, vasopressin, or norepinephrine to help constrict blood vessels and support blood pressure.
And if there are other complications like anemia or those clotting problems, DIC.
The source mentions using whole blood or packed red blood cell transfusions for significant anemia. For DIC or other coagulopathies, fresh frozen plasma might be given. Canine albumin transfusions can be used for severe hypoalbuminemia, low protein.
That's a massive amount of medical stabilization. What about just basic nursing care?
Nursing care is incredibly important. It goes beyond just managing fluids and meds. Things like frequently changing the patient's position in the kennel, maybe every 4 to 6 hours, is highlighted. That helps prevent pressure sores and may improve ventilation.
What about feeding them? Can they even eat?
Diet is obviously influenced by the underlying cause, but a major point emphasized in the source is the critical importance of early nutritional support.
Early, even when they're so sick.
Yes. The recommendation is often to place a feeding tube, like an esophagostomy tube, gastrostomy tube, or even a jejunostomy tube further down during the exploratory surgery.
Why is feeding them so crucial, even through a tube?
The research explains that getting adequate nutrition started early is essential for optimizing the outcome. It helps fuel the immune system, attenuates the body's hypermetabolic state, supports liver defenses, prevents malnutrition setting in, and importantly, helps maintain the integrity of the gut barrier. That can help prevent more bacteria from translocating or moving across the gut wall.
Okay, so stabilize them medically, intensive nursing, get nutrition planned. Then is surgery always the next step?
The decision depends a bit on the specific cause, how the patient responds to stabilization, and realistically, owner finances play a role. But the source is very clear. Surgical intervention is necessary if you have known bacterial contamination or even just suspected chemical peritonitis, like from bile or urine.
And the timing of surgery.
It should be done as soon as the patient is considered stable enough to tolerate anesthesia and the procedure. Delaying isn't good if surgery is needed.
What actually happens during the surgery? What are the goals?
It's typically an exploratory laparotomy, opening the abdomen widely from xiphoid to pubis to get a good look. The main goals, according to the text, are find and remove or repair the source of the contamination, debride any dead tissue, thoroughly clean the entire abdominal cavity, collect samples for culture and gram stain, and place that feeding tube for nutritional support.
What about suture material inside the abdomen? Does the source mention specifics?
Yes, it recommends using monofilament suture, either absorbable or non-absorbable. It advises against using multifilament suture, non-absorbable types in contaminated fields generally, and specifically mentions avoiding catgut due to its inflammatory nature.
And clean the abdomen, you said that's a goal. How do they do that?
It's a meticulous process called lavage. The source describes using a large volume, 200 to 300 milliliters per kilogram of body weight, of sterile saline solution, warmed up to body temperature. They essentially flush the abdomen repeatedly.
Do they add anything to the saline? Antibiotics?
No, this is a key point from the text. Do not add antimicrobials or other products like povidone iodine to the lavage fluid, just warmed sterile saline. And it's critical to remove as much of that lavage fluid as possible before closing the abdomen.
What if the source of contamination is really bad, like a big abscess, so they can't completely remove all the infected tissue?
That's when the source discusses considering open abdominal drainage.
Leaving the abdomen open.
Well, there are different techniques described. It might involve placing closed suction drains, using a vacuum-assisted closure system, VAPD, or even just partially closing the incision, allowing continued drainage. The decision is based on how severe the contamination is, whether they could adequately debride everything, and how sick the patient is.
That sounds intense.
It is. The text notes it requires significant post-operative management, like sterile bandaging changes, potentially repeat anesthesia for bandage changes or drain management, and it has its own set of potential complications.
Okay, so medical support, surgery to fix and clean, possibly open drainage. What about medications? Antibiotics must be key.
Absolutely critical. The source stresses the need for early and aggressive administration of broad-spectrum antibiotics if septic peritonitis is suspected. You need to cover gram-positive bacteria, gram-negative bacteria, and anaerobes initially.
Broad spectrum first, then refine it.
Exactly. The final choice must be based on the culture and susceptibility results when they come back. But you can't wait for those. The text gives examples of initial empirical choices. Maybe a fluoroquinolone like enrofloxacin or an aminoglycoside like amikacin for gram-negatives, often combined with something like ampicillin or clindamycin for gram-positives. And metronidazole is frequently added to cover anaerobic bacteria.
And pain control. This sounds incredibly painful.
It usually is significant pain. The source strongly recommends aggressive pain management. Opioids are the mainstay, often given as a continuous rate infusion or CRI. The text gives examples of multimodal CRI combinations, maybe mixing an opioid like morphine or fentanyl with ketamine and or lidocaine, depending on the species and needs.
Any other standard medications used?
GI protectants are often recommended. Because of the poor perfusion and stress associated with peritonitis, there's a high risk of stomach ulcers. The source mentions H2 blockers like famotidine or proton pump inhibitors like pantoprazole, noting that IV pantoprazole gives faster and more complete acid suppression. Sucralfate might also be used to coat ulcers.
Are there any medications the source specifically warns against using?
Yes, this is important. Glucocorticoids, steroids, are listed as controversial in this setting. NSAIDs are explicitly not recommended due to risks like GI ulceration and kidney injury. And using heparin for DIC is noted as potentially less effective if the patient's antithrombin levels are low, so its use requires careful consideration.
Any specific precautions with the drugs that are used?
Yes. For aminoglycoside antibiotics, like amikacin, the text stresses caution if there's pre-existing kidney impairment. Adequate hydration is essential when using them, and a really crucial precaution. Anti-nausea medications, antiemetics, should generally be avoided if a GI foreign body or rupture is suspected until that cause has been definitively ruled out by surgery or imaging. You don't want to mask signs of ongoing leakage or obstruction.
That makes sense. Okay, so treatment is incredibly intensive. What does the recovery period look like? What kind of follow-up is needed?
Patient monitoring has to remain very frequent and intensive, especially right after surgery. The source mentions it could be hourly, depending on severity. You're constantly watching fluid balance, electrolytes, acid-base status, blood gases, lactate levels, urine output, making sure those fluid therapy goals are being met.
Still replacing fluid losses?
Yes, replacing ongoing losses from drains or abdominal effusion is critical. Continuing that regular turning or repositioning of the patient is also important.
And the nutrition through the feeding tube.
Keep that going. Early enteral nutrition feeding into the gut is emphasized repeatedly in the source for promoting gut health, providing calories, and potentially decreasing bacterial translocation.
What if they suspect something went wrong with the surgery, like a leak?
The text mentions that repeating imaging, like an ultrasound, and potentially resampling abdominal fluid for cytology can be done if there's concern about breakdown or leakage from a surgical site, like a GI repair. Regular lab work, CBC, chemistry panel, is usually checked every day or two during the intensive phase.
Can peritonitis actually be prevented?
Generally, it's difficult, according to the source, unless there's a specific known risk factor you can address beforehand. Like, spaying a female dog prevents pyometra, which eliminates that specific cause of septic peritonitis. But many causes are spontaneous or trauma-related.
What are the main complications to watch out for, even if treatment seems successful initially?
Well, complications can arise if the underlying cause isn't completely managed. Those open abdominal drainage techniques, while sometimes necessary, have their own list of potential issues mentioned in the source. High cost, intensive care needs, risk of hospital-acquired infections, protein loss, electrolyte imbalances, and even things like fistulas or hernias developing later. Long-term adhesions can sometimes cause problems, too.
Which leads us to the bottom line, the prognosis. How likely are these pests to survive?
It really varies. Prognosis depends heavily on rapid diagnosis, successful surgical management of the underlying cause, and the quality of the postoperative intensive care. But the source is stark. For septic peritonitis specifically, the mortality rate is reported to be high, somewhere in the range of 30% to 68%.
That's very high. Are there specific factors that make the prognosis worse?
Yes, the text lists several factors associated with a poorer outcome. Things like already having established septic peritonitis at the time of diagnosis, persistent low blood pressure that doesn't respond well to fluids, having low serum albumin or total protein levels, low levels of natural anticoagulants like protein C or antithrombin, evidence of respiratory dysfunction having DIC or developing MODS.
And conversely, what factors suggest a better chance of survival?
The research points to some factors associated with better survival, things like lower preoperative liver enzymes, ALT, GGT, lower PCV, and total solids initially, certain findings on thrombolistography suggesting hypercoagulation rather than breakdown, and higher albumin levels seem to be linked to better outcomes.
You mentioned open drainage earlier. Did the source say if that actually improves survival?
It notes that open peritoneal drainage may improve survival rates in some studies of septic peritonitis, though it comes with those aforementioned complexities. And there's a striking comparison given for bile peritonitis. One study cited showed survival for septic bile peritonitis was only 27%, whereas survival for non-septic bile peritonitis cases was 100%. That really highlights the devastating impact of the infection itself.
Wow. And what about the timing of treatment? Did the source have data on how much difference that makes?
Yes, this was a really powerful statistic from the text. For patients with suspected septic peritonitis, initiating appropriate antibiotic therapy based on established hospital protocols within the first hour of identification was associated with a massive reduction in mortality, dropping it from around 80% in delayed cases down to about 42%.
80% down to 42%.
Mhm.
Just by starting antibiotics quickly. That's incredible.
It absolutely underscores the urgency. The source also mentions that a plasma lactate level remaining high, above 2.5 millimole, or an inability to bring the lactate down with treatment is a strong predictor of poorer survival in septic peritonitis cases.
And those feeding tubes.
Yeah.
Any specific complications tied to them mentioned?
The text briefly notes potential complications depending on the tube type and placement site, things like infection at the site, leakage around the tube becoming dislodged, and also refeeding syndrome, which is a potential metabolic complication when you restart nutrition in a severely malnourished patient, needs careful monitoring.
Any final specific poor prognostic indicators just for cats from the source?
Yes, for cats specifically with primary septic peritonitis, the text notes that bradycardia, that slow heart rate we discussed earlier, and hypothermia, having a low body temperature, were associated with mortality.
Wow. This deep dive into the source material has really laid bare just how incredibly complex and frankly life-threatening peritonitis is.
It really has. It shows that intricate, almost runaway inflammatory cascade happening inside, the signs that can be so subtle at first but escalate rapidly.
Yeah, and the diagnostic hurdles, needing specific things like that fluid analysis for definitive answers.
And then the sheer intensity of the treatment, the massive fluid resuscitation, the complex surgery, the potential for open drainage, the critical care monitoring around the clock, the targeted medications. It's a huge undertaking.
Reading through the source material definitely gives you a profound appreciation for the gravity of the condition and just how demanding it is to manage.
It's far, far more than just a bad tummy ache, isn't it? It's a true systemic crisis.
Absolutely.
Eh.
So here's something to think about, drawing from what we've uncovered in this source. We saw that dramatic impact of early antibiotic treatment on survival. Considering that and the complexity of surgically fixing the root cause, how much weight do you give the timing of intervention, getting those initial steps like fluids and antibiotics going fast compared to the specific type of underlying problem when it comes to predicting who survives?
That's a great question. Or maybe reflecting on that detailed pathophysiology. How much does the body's own inflammatory response, which starts as protective, ultimately contribute to the overall severity and organ damage, sometimes maybe even as much as the initial leak or infection itself? How does that balance shift?
Really interesting points to ponder, stemming right from the details in the text. That brings us to the end of this deep dive.